Let us continue with this topic, posterior pituitary hormones. In the hypothalamus, you have supraoptic nucleus and paraventricular nucleus, and these nucleus have neurons. They have the bodies in the hypothalamus, and they have their nerve terminals in the posterior pituitary gland. Inside the neuron of the supraopticular nuclear neuron, the cell body, they have the ADH hormone. That is, the cell bodies of the supraoptic nuclear neuron, they synthesize ADH hormone, and the same goes for paraventricular nuclear neuron. The cell body, they synthesize oxytocin. There is ADH hormone along with neurophycins. This ADH hormone inside the cell body of the neuron, supraoptic nuclear neuron, along with neurophycins. Neurophycins is a carrier protein. They pass through the axon down the supraoptic neurohypophyseal tract to the posterior pituitary gland. This hypophysis, what is a hypophysis? Pituitary gland is also known as hypophysis. So supraoptic, since the pituitary gland is derived from neural tissue, supraoptic neurohypophyseal tract, this is known as supraoptic neurohypophyseal tract. And the oxytocin also pass from the paraventricular nucleus down to the nerve terminal, and here the ADH and oxytocin are released into the circulation. Here know one thing, that the ADH and oxytocin are synthesized in the hypothalamus, in the supraoptic nuclear neuron cell bodies and paraventricular nuclear neuron cell bodies, and the release of ADH and oxytocin, they occur in the posterior pituitary gland. So if there is a trauma to the pituitary stalk, and if the pituitary stalk is damaged, what happens is the posterior pituitary hormones are stopped for a while, and after 1 to 2 days the synthesis of these hormones, it will occur automatically after that. It is because the synthesis, it happens in the hypothalamus, and when pituitary stalk is damaged, there will be low levels of these hormones in the circulation, since these nerve terminals act as a storage vesicle for these hormones. Storage and release happens in the posterior pituitary, and after a few days the levels will come back normal, since the synthesis occurs only in the hypothalamus, so there won't be any problem in the synthesis. Know that in hypothalamus the synthesis of these hormones happen, and in posterior pituitary gland the storage and release happens. The ADH and oxytocin are structurally similar and only different functionally. ADH and oxytocin has 9 amino acids in each, and they share 7 same amino acids. Only the difference is 2 amino acids. The function of ADH is antidiuresis, that is water reabsorption, and the function of oxytocin is milk let out, and also during delivery it helps in the myometrial contractions. So now let us see the antidiuretic hormone in detail. In hypothalamus, anterior to the hypothalamus, you have two organs, organum vasculosum and subfornical organ. This organ is called subfornical organ because above the subfornical organ is the fornix area. If you have studied the neuroanatomy, you would have known these structures already. So now you know above the hypothalamus you have third ventricle, and these organs are situated antroventral to the third ventricle, that is in the front side, and in between these organs you have a structure called as median preoptic nucleus. These organs, they are located or we can say they sit in lamina terminalis. So what is so special about this subfornical organ and organum vasculosum? It is because in that area the blood brain barrier is very loose, that is the blood can enter this area, so that the osmoreceptors which are present inside the subfornical organ and organum vasculosum can directly sense the contents of the blood. If the blood carries any foreign substance such as opioid, and it can also sense the blood chemistry, etc. So that's why the subfornical organ and organ vasculosum are so special in this lecture. And you know that ADH, the function of ADH is antidiuresis, that is water reabsorption. In an overview, we know that ADH, the function of ADH on blood vessels is vasoconstriction, and the function of ADH on kidney is antidiuresis. For vasoconstriction, it needs more ADH, and for antidiuresis, it needs only less ADH. I will come to this later in this lecture, why vasoconstriction they need more ADH and why for antidiuresis it needs only less ADH. And we have already seen in the previous lectures months before, in the regulation of respiration, you have the pressure sensors, the carotid sinus and right and left atria. The carotid sinus is connected through the glossopharyngeal nerve to the tractus solitarius in the medulla oblongata, and this right and left atria is connected through vagus nerve to the tractus solitarius, which is located in the medulla oblongata. The function of carotid sinus is to sense the blood pressure, and the function of right and left atria is to sense the volume of blood. If there are any changes in the blood pressure, the carotid sinus will pass the signal through the glossopharyngeal nerve to the tractus solitarius. And if there are any changes in the volume of the blood, that is, if there is a blood loss, it will send the signal through vagus nerve to the tractus solitarius in the medulla oblongata. So these are mammillary bodies, hypothalamus, and here is your pituitary stalk, and here is your posterior pituitary, anterior pituitary, and here is your brainstem, cerebellum, and other parts. So these signals in turn it will go to the median preoptic nucleus. That's why I have mentioned this median preoptic nucleus here. The osmoreceptors which is present inside subfornical organ and organum vasculosum, they detect or they sense the blood contents. They also send signal to this median preoptic nucleus, and these signals they are sent to this supraoptic nucleus. And this stimulate the synthesis of ADH hormone in the supraoptic nuclear neuron. ADH hormone, antidiuretic hormone, it means it does not allow water loss in urine. That is why it is called antidiuretic hormone. The function is antidiuresis, that is water reabsorption, or it save water. ADH is a water conserving hormone. Usually the blood is hyperosmolar. What is hyperosmolar? The blood contains salts such as sodium and chloride, etc. The blood also contains glucose and other substances. So the blood is usually hyperosmolar. The normal osmolarity of blood is the exact value is 290 milliosmol per liter. So if there is no water in the blood, what happens is the blood concentration will increase. It is because there will be no water, but there are other substances, so their concentrations are increased. So the body fluids are now hyperosmolar. So now due to the increase in blood concentration, there will be increase in the blood pressure. Because there is no water, the blood volume is decreased. So if there is more water, what happens is if there are more water in the blood, the blood concentration will decrease, as the blood will have only more water and the other substances are kicked out. Now we can say the body fluid is hypoosmolar. Now the blood pressure is decreased, and also since more water comes into the blood but the other substances are kicked out, the blood volume remains unchanged. That is, the blood volume is also decreased. Please understand the concept practically. So the osmoreceptors which are present in the subfornical organ and organum vasculosum, when they sense if the blood has no water, the organs will shrink and they will give order to the body to release water. We will discuss how it happens in the coming lecture. And if there is more water, these osmoreceptors will sense that, and these organs, they will swell and it will conserve the water in the body. So in such a way the osmolality of blood is maintained in the body. I will discuss about this in the next slide. So the median preoptic nucleus, the function of median preoptic nucleus is it can sense the osmolality of the blood, it can also sense the blood chemistry, and also it can sense the blood pressure and volume of the blood. Since all the signals are going to it, and through median preoptic nucleus the ADH is synthesized. Through the median preoptic nucleus, the supraoptic nuclear neuron are stimulated and ADH is synthesized. The ADH hormone
it acts on kidney and also on blood vessels. On kidney, the function of ADH is diuresis, and on blood vessels it is vasoconstriction. Here is a diagram of a nephron, the kidney. So for the better understanding purpose, we will take a round-off value of the normal osmolality of blood, that is 300 milliosmol per liter, but make sure you know the exact value, 290 milliosmol per liter. So let me first tell you the parts of the nephron. You have Bowman's capsule, proximal convoluted tubule, descending loop of Henle, and the interstitium area, then thin ascending loop of Henle, then it goes to thick ascending loop of Henle, then distal convoluted tubule, and then the large part of distal convoluted tubule, and collecting tubule, and the collecting duct. So this is the medullary interstitium area. Here you also have blood vessels, named vasa recta. So now in the circulation, the blood osmolality level is 300 milliosmol per liter, and it goes to the nephron with this diffusion process. So the values, they won't change, it remains the same. In the proximal convoluted tubule, there is isoosmolar absorption, that is, the solutes are in equal proportion as the water in the fluid that is present inside the lumen. So what are solutes? Solutes are the sodium, chloride, ions, etc. So the solute and water here are in equal proportion, so the value remains unchanged until the end of proximal convoluted tubule. So what happens in the descending loop of Henle is the fluid start to move out, that is the water, they will move out, and more solutes from outside, it will begin to come inside. So what happens is the luminal fluid here in the descending loop of Henle, and when it goes to medullary interstitium and in thin ascending loop of Henle, the fluid has no water, or we can say very less water, but more solutes, since the fluid is going out and the solutes are coming inside. So this area, it will be highly concentrated, since the fluid has only solutes. So the value, that is 300 milliosmol per liter, it becomes 1200. So this is known as a concentrating segment, and until here thin ascending loop of Henle, the value is 1200 milliosmol per liter, and the fluid, when it goes to the thick ascending loop of Henle, what happens is, first know one important feature of thick ascending loop of Henle, it is a watertight container, that is, it will never allow water to go out. So here the water cannot move out, so only solutes go outside. So what happens is there will be more water content in this fluid and very less solute, since solutes move outside and water come inside, but the water inside, they cannot move out. So here the fluid has very less amount of solutes and more water. So this automatically becomes a hypoosmolar fluid. Here it is hyperosmolar. So the value, it becomes 50 to 100 osmol per liter. So we call it as a diluting segment. So in the distal convoluted tubule, until the later part of distal convoluted tubule, the fluid is hypoosmolar. So when this hypoosmolar fluid, when it comes to the collecting tubule, here you will see the action of ADH hormone. So we will see this in a short while. Here, as I have mentioned earlier, that in the medullary interstitium you also have blood vessels. Since the more solutes from the luminal coming outside, luminal fluid coming outside, what happens is the same amount will diffuse into the blood vessels, and the concentration of blood, it becomes higher. So the blood becomes hyperosmolar in these blood vessels. So what happens in hyperosmolar blood? The blood flow becomes slower. It is because the blood here in this area, it contains less amount of water and more solutes. So the blood vessels named vasa recta here have a slow blood flow. Here are the cells present in the nephron attached to it. Here I have enlarged one cell to explain what happens inside this cell, so please do not get confused. And you know already that the blood vessels here, the blood is hyperosmolar, and in the circulation there is already ADH hormone. So a slight increase in the ADH hormone, that is, whenever there is hyperosmolar, the function of ADH hormone is antidiuresis, that is water reabsorption. So what happens is the blood here is hyperosmolar, there is no water. So now the function of ADH is to absorb water into this blood vessel. So the ADH will increase in the circulation so that the water is reabsorbed inside these blood vessels. So whenever there is a slight increase in the ADH, what happens is, this is one cell in the last part of distal convoluted tubule. This ADH, this slight increase in ADH, it will act on the serpentine receptor and activate the G stimulatory protein. This serpentine receptor in nephron is also known as vasopressin receptor or V2. So this ADH, when it acts on this 1-pass transmembrane receptor, what happens is the G stimulatory protein is activated and it stimulates the adenyl cyclase. In turn, there will be increase in cyclic AMP and production of protein kinase A, and this will lead to the phosphorylation of vesicles inside the cells. So there are vesicles in the cells which have aquaporins. Aquaporins are pores like structures. They normally present in the basolateral membrane. So, and they also present on the vesicles. After the phosphorylation, what happens is, these protein channels named aquaporin 2, they will get detached from these vesicles and they will get attached to the luminal membrane. that is the membrane of the later part of DCT, collecting tubule and collecting duct. So now what happens is the fluid here inside the lumen, it has more water and very less solute. So now the water will move through these pores inside the interstitium into the blood vessels. So we have seen already that the blood is hyperosmolar here due to the increased amount of solutes and less amount of water. Now because of this ADH action, the water is reabsorbed into the interstitium and into the blood vessels. Now what happens is it will prevent the further increase of the hyperosmolarity of the blood. So this is how the ADH comes into action. So now you have seen the water is reabsorbed. This is the function of ADH. It saves water, or it reabsorbs water. If there is no ADH, what happens? The fluid inside the lumen, it will go as a diluted urine. That is, if in this lumen the fluid has more solutes than water, so this is a concentrated fluid, and here you have more water than solutes, so this is a diluted fluid. And this diluted fluid, if there is no ADH and if there is no reabsorption, it will go as a diluted urine. If there is ADH, what happens? Water get reabsorbed into the interstitium and into the blood vessels, and now it goes out as a concentrated urine since it has less amount of water. So now we will see the function of ADH on the blood vessels, that is vasoconstriction. We have seen here that it needs slight increase in the ADH level to activate the vasopressin, that is V2 receptor, to stimulate the G stimulatory protein to reabsorb the water. In the muscle tissue cell, what happens is you have vasopressin receptor V1. In nephron you have vasopressin receptor. In nephron, in the later part of distal convoluted tubule, in the cells you have V2 receptor. Here it needs high level of ADH to activate the V1 receptor to stimulate the GQ protein inside this smooth muscle cell, and this GQ protein in turn it will lead to the phospholipase C formation, and it will act on the phosphatidyl inositol biphosphate. This phosphatidyl inositol biphosphate will divide into diacyl glycerol and inositol triphosphate. This diacyl glycerol, it will lead to the formation of phosphokinase C. In nephron, in the cells of the later part of distal convoluted tubule, there is the formation of protein kinase A. In the smooth muscle cell, you have the formation of protein kinase C. This protein kinase C activate or stimulate the contractile protein, which lead to the smooth muscle contraction. And this phosphatidyl inositol biphosphate, you will see this in endoplasmic reticulum too. In endoplasmic reticulum, you also have calcium pump channels. So when this inositol triphosphate act on the endoplasmic reticulum, what happens is the intracellular endoplasmic reticulum calcium present inside the endoplasmic reticulum, they will move outside, and this intra endoplasmic reticular calcium binds with calmodulin and it will form calmodulin protein kinase, and this calmodulin protein kinase, it will activate a stimulate the contractile protein, and it will also cause muscle contraction. So whenever there is a smooth muscle contraction, the blood vessels also get constricted, so there will be contraction of the blood vessels also. So this is how the ADH constricts the blood vessels. So I will summarize again the differences between the ADH action on nephron and the smooth muscle. In nephron, the ADH act through the vasopressin receptor V2. In the smooth muscle cell, the ADH act through the vasopressin receptor V1, and here the V2 receptor, the ADH, it stimulates the G stimulatory protein, and here it stimulates the GQ protein, and here in the cells of the later part of distal convoluted tubule, protein kinase A is formed. Here in the smooth muscle cell, protein kinase C is formed through diacylglycerol, and calmodulin protein kinase is formed through inositol triphosphate. And also you should know importantly that a slight increase in the ADH in the circulation, it will activate the V2 receptor and stimulate the GS protein. Higher levels of ADH, it will activate the V1 receptor and stimulate the GQ protein. So for the vasoconstriction, there should be higher levels of ADH in the circulation, and for the diuresis, for the antidiuresis, you need a slight increase in the ADH level. Now we will see ADH system, that is antidiuretic hormone system, in water deprivation, polydipsia, circulatory shock, cranial or central diabetes insipidus, and nephrogenic diabetes insipidus. So when you have water deprivation, that is if you do not drink enough water, or if you do not drink any water, what happens is your blood, it automatically becomes hyperosmolar, and in order to compensate that, there will be increased levels of ADH in your circulation. And what happens is a slight increase in the ADH in the circulation, it will activate the V2 receptor and stimulate the GS protein, and the water is reabsorbed. So you have, what do you have here? Hyperosmolar urine, that is water is reabsorbed back, and you will have a concentrated urine, and this fluid is known as hyperosmolar. So what happens during polydipsia? Polydipsia is a medical term that refers to when a person drinks too much water. It is a psychological condition of drinking too much water so that he thinks he is healthy. If there is too much water, what happens is the blood, it is hypoosmolar. The blood is not concentrated here because already the patient is drinking often too much water. So if there is too much water, what happens is the blood here become hypoosmolar. So in order to compensate that, the ADH, it will not release, so the circulation ADH, it will be very low. And also know that the water is not reabsorbed because there is no ADH, and also there is very low ADH in the circulation, so you will pass a diluted urine. We call it as hypoosmolar urine. So what happens in a circulatory shock? Circulatory shock means if a patient lose 15 to 20% of blood from his body, what happens is you know 15 to 20% blood loss. The volume of blood becomes very low, and we have discussed earlier in the lecture that if any disturbances to the volume of blood happens, the signals are sent through vagus nerve to the tractus solitarius, and it will stimulate the median preoptic nucleus, and this median preoptic nucleus in turn it will activate the supraoptic nuclear neurons, and here you will have the synthesis and release of ADH into the circulation. So now this is in circulatory shock. So what happens is once there is increase in the ADH in circulation, the water is reabsorbed and it compensates for the decrease in the volume of blood. Now we will see cranial or central diabetes insipidus. In cranial or central diabetes insipidus, the blood is hyperosmolar. The blood is hyperosmolar as usual, but the word itself describes it's a cranial diabetes insipidus. That is, there is some disturbances in the hypothalamus. So if there is disturbances in the hypothalamus, what happens is the synthesis of ADH is disturbed, so that there will be very low ADH release in the circulation. If there is very low ADH release into the circulation, what happens? The water cannot get reabsorbed, so you will pass a diluted urine. So you will have a hypoosmolar urine. So what are the causes of this cranial or central diabetes insipidus? The causes are infection, trauma, congenital diseases. So if there is a infection, trauma, congenital diseases to the hypothalamus, what happens is the synthesis of ADH is either it is decreased or there is no synthesis at all in the supraoptic nucleus. So what is the treatment given for this condition is synthetic ADH, that is desmopressin. That is, since there is no ADH or decreased synthesis of ADH because of these causes in the supraoptic nucleus, we give externally the ADH in the circulation so that the levels are compensated. Now we will see nephrogenic diabetes insipidus. In nephrogenic diabetes insipidus, the blood is usually hyperosmolar. So if the blood is hyperosmolar, there will be increase in the ADH in the circulation, and it should lead to the reabsorption of water, and the patient should pass a concentrated urine, that is hyperosmolar urine. But in nephrogenic diabetes insipidus, what happens is the blood is hyperosmolar, there is increased level of ADH, but the kidney is not responding to this ADH stimulation. There is disturbances in the serpentine receptor, that is vasopressin receptor V2, so that the water is not reabsorbed and the patient will pass hypoosmolar urine, that is the urine with more content of water. So what are the causes for this nephrogenic diabetes insipidus, such as renal medullary diseases, lithium carbonate drugs. Lithium carbonate drugs, those who are with depressive disorder, they take this lithium carbonate drugs, and this lithium carbonate drugs is very effective, that it will cure the depression, but it will lead to nephrogenic diabetes insipidus, since this lithium carbonate, it will make the kidney unable to respond to the ADH. So then you have the tetracycline, that is demiclocycline drugs.
Now, how will you differentiate a patient has cranial diabetes insipidus or a nephrogenic diabetes insipidus? This we can identify by giving desmopressin, that is synthetic ADH injection. When you give synthetic ADH injection, that is desmopressin, the urine, if the urine turns hyperosmolar, then the patient has cranial diabetes insipidus. Even after giving desmopressin, if the urine remains hypoosmolar, then it is nephrogenic diabetes insipidus. Because in cranial diabetes insipidus, when you give synthetic ADH desmopressin, already the level of ADH is very low. When you give desmopressin, the ADH level will rise, and this will lead to the reabsorption of water, and the urine will become hyperosmolar. It will respond to the treatment. But in nephrogenic diabetes insipidus, if you give desmopressin, it is of no use because there is already increase in the ADH. But the kidney, the problem is with the kidney, so the urine remain hypoosmolar. Now, how will you differentiate nephrogenic diabetes insipidus and polydipsia? Polydipsia is a condition where the patient drinks excess amount of water. So now advise the patient to stop drinking water and let him come the other day, the next day. So when the patient stop drinking water, what happens is the blood becomes hyperosmolar and there will be increased ADH in the circulation and the urine will become hyperosmolar. So you can easily identify that this is a polydipsia condition. Even though after the patient stops drinking water, the next day the urine is still hypoosmolar, that means the patient has nephrogenic diabetes insipidus condition. So next we will see a syndrome known as syndrome of inadequate ADH secretion. This syndrome of inadequate ADH secretion, it happens in the hypothalamus. It is usually due to the lung tumor, especially small cell carcinoma. Why lung tumor causes inadequate ADH secretion in the hypothalamus? It is because for the treatment of lung tumor you give demiclocycline, and small cell carcinoma responds highly to demiclocycline. So what happens when you give demiclocycline drugs? It will lead to nephrogenic diabetes insipidus, that is there will be increased amount of ADH levels in circulations and the patient will pass hypoosmolar urine. Now we will see the factors which increases the levels of ADH and which decrease the level of ADH. During water deprivation, that is if one do not drink enough water, what happens is there will be increase in the plasma osmolarity level. If there is increase in plasma osmolarity level, it will increase the ADH level also. And during circulatory shock, that is if a patient loses 15 to 20% of blood from the body, the blood volume become decrease, the blood pressure also decrease. This in turn it will increase the ADH levels, so that the blood volume and pressure levels are compensated. Nausea and vomiting are strong stimulants of increase in the level of ADH, because during vomiting you will lose water from the body. So for compensation for that, there is increase in the ADH which will reabsorb water again into the body. And hypoxia, hypoglycemia, they stimulate sympathetic nervous system, which in turn will increase the ADH levels. There are many other drugs which also increases ADH,
but particularly we will discuss about morphine and nicotine. They stimulate the supraoptic nucleus, and it will lead to increase in the level of ADH. So the factors which decrease the ADH level are decrease in the plasma osmolarity. That is, if a patient or if a person drinks more water than normal, what happens is the plasma osmolarity level decreases, and this in turn it will decrease the ADH level, so that the water reabsorption is stopped. It will be compensated, and during blood transfusions, what happens is there will be increased blood volume, and which will increase the blood pressure during blood transfusions. This in turn it will decrease the ADH levels in the body, and also consuming alcohol. Consumption of alcohol also decreases ADH hormone level, so that in alcoholic patients you see diluted urine, and because of the decrease in the ADH level. So that's it for posterior pituitary hormones.